Dear friends, welcome to the show Talk with Your Doc. I'm Dr. Prashant Jani, and our guest for today is Dr. Walid Shahrour.
Thank you.
He is a neurosurgeon at Thunder Bay Regional Health Science Center. This is the month of November, and it's a prostate cancer awareness month. And our guest, Dr. Walid Shahrour, is going to guide us about how to diagnose prostate cancer at earlier stage, various methods of diagnosis, various treatment options, and prognosis after the treatment. Thank you, Dr. Shahrour, for coming to the show.
Thank you.
How often you see prostate cancer in your practice?
Well, prostate cancer is quite often. It's one of the main diseases that we deal with as urologists. I would say in every day, like if I'm going to be seeing, for example, 30 patients, I would see at least 4 to 5 patients who are just prostate cancer. And we diagnose a week, or actually in a month, between 15 to 20 patients with prostate cancer in Thunder Bay and the Northern Ontario region.
So the frequency is quite frequent,
It is. Well, it's the second most common cancer in men. And as we are having more and more of an aging population, it's bound to show up more and more.
Right. So prostate cancer is the second most common cause of death, probably after the lung cancer.
It is true.
And the incidence is growing, or you think, or we are detecting at earlier stage probably?
Right now what's happening is that the population is aging and we're having more capacity to diagnose and screen for prostate cancer. We're finding it happening more and more. There has been quite a decrease actually in the past 5 years in detection, but it wasn't because there's a true decrease, but actually because of actually a decrease in the amount of screening being done, because there was a wave of not screening for prostate cancer, especially after the prostate cancer screening report, the prostate cancer task force that came in the US in 2012, and they recommended initially against prostate cancer screening. So a wave of doctors and physicians, they stopped doing prostate cancer screening. And interestingly, this has reversed. And they came up last year saying that, you know what, prostate cancer screening should be a discussion between the patient and the physician, which is basically what we have always been doing.
So the reason of that questioning of the screening might be because not all patients with prostate cancer would die with the cancer?
Not only that, not all patients with prostate cancer might benefit from treatments. Okay. And we have to be careful. We should not be aggressive in the way we treat. We should be tailoring the treatment or no treatment depending on the patient situation, and what are we expecting to happen. Mm-hmm. So this is basically where we are right now.
So what is the age group of the patients you see in your practice affected with prostate cancer?
I have seen as low as 45 years old, 45, all the way up to 95 years old, so 97.
It's quite a big of range.
It's a very big range, and we know the younger you are, the less chances of prostate cancer. But as we get older, being older is one of the risk factors for having prostate cancer. Right. So I always tell my patients, just like a rough estimate, if you're 60, if I have 100 patients who are 60 years old, between 60 and 70, there's a 60% chance we're going to find cancer. It doesn't mean that this cancer is a significant cancer that we have to treat.
Right.
So we have to understand there's a big difference between incidence and actually if we need to treat that cancer. And most of the prostate cancers are not aggressive.
Yes.
It is becoming more and more of a chronic disease.
Yes.
Today I had a patient, I was telling them, listen, you have cancer. It's a very low-grade cancer, Gleason 6, which is basically the lowest possible cancer, and only found in 2 cores. You do not need to worry. We're going to watch it, and we're going to deal with it as if it's a chronic disease.
So as soon as you hear a diagnosis of prostate cancer, one should not get scared about it.
I always make sure that I tell them, look at me. Do you see me worried? They tell me, yeah, but you don't have the cancer, doctor. I'm like, yes, but you should not be worried. Prostate cancer is not commonly aggressive.
Yes.
And even when it is aggressive, we have a lot of ways to deal with it. So we should not be afraid when we have it. Yes. We should start changing our mentality a little bit into, like, we have to deal with it, and like if we need to treat it or not, but we do not need to panic or start writing your will.
Right, right. Now, do you see there is a geographic variation or incidence change in the prostate cancer as comparing America versus Asian countries?
Well, we know that incidence of prostate cancer is higher in North America and Western Europe than in Asia or Africa. But we have to put in our mind that this is different than the race factor. because we know that, for example, if you're an African American, you have higher chances of having prostate cancer. So why is it less in Africa? Well, they're not screening as much.
Oh,
We're blessed in Northern America and in Europe that we have the healthcare system that we can actually go for a screening. And you want to go for your doctor, and the doctor will check you. Well, if you go to Asia or Africa, there are for sure excellent doctors there, but the access is not as readily available, and the screening is not always available there.
So screening at our Thunder Bay Regional Health Science Center, how do we do the screening at our hospital here?
So right now, in the past year and a half, so when I came into Thunder Bay 4 years ago, it was just basically the doctor, if anybody did a rectal exam or a PSA, which is the blood test, they would basically, if they find that the PSA is high or usually above four,
yeah.
they would refer to the urologist. But
Yes.
we were only like few urologists, we were two only, and the referral would take maybe sometimes a year,
Oh.
a year and a half, and sometimes patients with more developed cancer would be delayed a little bit. Well, actually quite a bit, I would say. So we worked on actually doing, there was like a lot of work between us, the cancer center, the screening program, and we developed what we call a diagnostic assessment program for prostate cancer. So now any patient who gets screened by their family doctor, or the doctor finds there's an abnormal rectal exam, digital rectal exam of the prostate, they would refer the patient. The patient usually gets seen within 2 to 4 weeks.
By a urologist?
By a urologist. Patient gets seen, examined, and there is a nurse with us in the program. We counsel the patient about the next step, if the patient needs to repeat the blood test or the patient needs a biopsy, and we explain everything to the patient, and then the patient goes for the biopsy. And we have worked, and we're working quite hard till now with the hospital, with various departments. Actually, pathology department was a major player in that, in reducing the wait times. So we have not published this yet, but we have gone from 150 days from referral to treatment. Now we're down into the, I think, 70s or 80 days. So we have gone down 50% almost, and we're still going for more and more.
Right.
The pathology department on its own has reduced the time from 4 weeks to 10 days or less.
Right. So when the PSA level is high, the next step for screening is the biopsy. And there are two types. One is per rectal biopsy, you do it. And then we were talking about the pelvic approach to the biopsy.
Exactly. So the traditional approach, if you go to like any center, usually it's the transrectal. So the probe goes through the rectum, and the needle of the biopsy goes through the rectum.
So is that very painful procedure?
Most of the time, it is not comfortable for sure. It is, like, for some people it's painful. We do local anesthetic, and it.
So exactly explain us, how does this process happens? Like, so patient comes to your
the patient comes to the the biopsy
procedure.
The patient comes in. They take antibiotics before,
Okay.
and they come in. They usually lay down on their left side. We have an ultrasound probe that gets placed into the rectum, and we see the prostate. We do not see usually cancer. We can just see the prostate and the location of the prostate.
And there is no anesthesia here.
There is no anesthesia.
Right? So patient lies down, and he can feel all the procedure going on.
They can feel. Usually we have a small, very tiny needle. We can actually freeze the prostate.
Yeah.
The pain becomes way less.
Okay.
And to say the truth, most of the time now, it's not as painful as before.
And then you take multiple biopsies
we take at least 12 cores, 12 biopsies.
And what is the reason of taking 12 or multiple cores?
Because we know that the prostate is has various areas, and we want to be able to get a sample from each area.
Every area.
Do we actually see the cancer? We don't. So I would say, I would tell the patient, if I look into my hand, I'm going just like this. But I know where I'm going, but it doesn't mean that I'm going into the cancer or not. So there's a chance you might miss it.
Right.
And this is why we have the next level, which is basically the MRI, or the magnetic resonance imaging of the prostate.
Yeah. We'll take a short break and we'll continue our discussion.
Perfect.
Please stay back for the next part. Thank you. Welcome back to the show, Talk with Your Doc. Our guest for today is Dr. Walid Shahrour. He's urologist at Thunder Bay Regional, and we are talking about prostate cancer awareness. Dr. Shahrour, you were mentioning about biopsy for the prostate cancer detection, and you mentioned ultrasounded guided biopsies are done.
Yes.
And then you do MRI approach biopsies also?
So right now we started in the last year and a half with with the radiology department. We have the MRI machine. We actually are able to do MRIs for patients where we're finding it hard to localize the prostate cancer, or they had negative biopsies and we want to make sure they're actually truly negative. We do an MRI, and it's the technology, top technology. We're trying to localize the high grade. The MRI does not localize the low grade or the less aggressive. It only sees the higher grade. And hopefully in the future, we're trying to collect the donations to buy actually a better machine to get a fusion between the MRI and the ultrasound. So it can actually tell me if we find the cancer on the MRI, I can get the images together over the ultrasound, and it tells me where exactly to go when
So
I'm
then
doing
you
the
don't
biopsy.
have to do two separate procedures, then it's all in one procedure.
The MRI is done on a separate time,
Yeah.
and then I have the
Ultrasound.
images from the MRI, and then I do the transperineal. Now, actually, nowadays we're trying to do a transperineal approach for the biopsies, which means less infection, no infection risk for the patients, and we're able to actually go directly to the tumor without having any difficulties. So this is where we're hoping for in the future, but we're still collecting some, trying to get the money and
Right.
the equipment.
Right. Now, does smoking increases the risk of prostate cancer, or diet increases the risk of prostate cancer?
In general, risk of prostate cancer with smoking or diet is not as, or like for example, obesity is not as clear. It does not show to be a culprit. For example, if you compare this to kidney cancer, where we know obesity or smoking are one of the risk factors. In prostate cancer, it is not the case.
So there is no exact cause of prostate cancer known?
We don't know.
We don't
like
know yet,
we for sure, we think if you go on the molecular level or the cell level, we say there is the DNA and DNA abnormalities and mutations and stuff like that, but we don't have. I cannot pinpoint a certain way.
So somebody's father has or uncle has a prostate cancer, does he have to worry about it?
It increases your risk. So if you have we know if you have a brother, it puts your risk up higher. If you have a father, it puts your risk higher. But an uncle, for example, paternal uncle, the family history, it plays a role for sure.
Okay. So what happens when somebody has prostate cancer? It's asymptomatic probably. Patient doesn't know he has a cancer.
Most of the time, prostate cancer, you don't have symptoms.
Yeah.
Because you know what? I tell the patient it's a silent killer. It just keeps on growing, and only you start having symptoms only when it's really, really bad.
It's bad, yeah.
So I have to say, prostate cancer is a very, very wide disease because we can go from the very, very aggressive tumor to the non-aggressive tumor that we're just going to follow. So it's a big discussion between the doctor and the patient, and we discuss the expectations, the treatment options. We have active surveillance, like for example, if a patient doesn't have an aggressive cancer, and we want to just follow it.
Yes.
That's an option. We can follow the patient, repeat the PSA, rectal exams, and sometimes repeat the biopsies. Other options we have is the surgical intervention.
Yes. So when somebody has no symptom and the patient is say 45 years of age, then he undergoes annual PSA testing, or?
So we say for the screening part, if you have no symptoms and you want to go for screening between the age of 40 and 50, you go for one PSA.
Once a year?
Only one time.
One time.
Between 40 and 50. And if it's normal, then you start at the age of 50 and you check it again. And depending on how high or low, if it's a low PSA, you can move your next PSA test and digital rectal exam, like it's usually yearly, the rectal exam. And the PSA can be moved to in 3 years from now. And then we check again. And all depends. If your PSA starts to go up higher and we're starting to have some suspicion that there might be a cancer, then we can go for.
So 40 to 50 years, one PSA test.
Yes.
And after 50, annual digital rectal examination, and every 3 years PSA then probably.
Depends again on
the
the
level,
PSA.
level.
Because if the PSA is high, I would not wait for 3 years. I'll
So
do it
PSA is a prostate specific antigen. It's a blood test, right? You
It is
just
a
draw
blood
the
test.
blood and send it to the laboratory.
It's a blood test that looks at the protein. It's a protein that gets produced by the prostate. It goes up and down for many reasons.
Yes.
If you have infection, inflammation, if you had sex the night before or 2 nights before, it might increase the PSA. If you have prostate cancer, having an enlarged prostate can also increase your PSA.
So PSA high doesn't mean you have a cancer problem.
And I always make sure the patient knows that your high PSA, you should not worry.
Yeah.
We repeat the test. We don't look at one value, we look at the trend of values, and this
Right.
is how we can reach a decision about biopsy or not, or what's the next step.
The PSA is a prostate-specific antigen which is secreted by the prostate within the blood, which is a normal substance actually.
Exactly. Every man has a PSA,
PSA, yeah.
unless you don't have a prostate.
Now, after the cancer treatment, also they screen the PSA, and that is for recurrence of cancer. Is that right?
So if you, for example, if you had your prostate removed, or if you had radiation therapy, which is one of the treatment options, or even the hormone injections, we look into the PSA, because at this point it's very important to tell, is the cancer recurrent or not? Do we have to worry or not? And this is one of the best way to look into the prostate cancer.
Right. So there's once the PSA is positive and the biopsy is positive, for example, then what happens?
Then the patient comes in for a lengthy discussion with the urologist and usually the radiation oncologist. We have a very good system here in Thunder Bay where every patient sees everybody. They see the surgeon and the radiation oncologist. They see the nurse. And we're trying even to get patient advocates from the prostate cancer group. And these patients the patient would be counseled on what are the options. Again, active surveillance, surgery, radiation, or hormones.
Now, suppose biopsy report comes with a Gleason score of 3 + 3 = 6, then those patients have better prognosis as compared to the cancer with the higher grade?
For sure, because the lower the grade, it's less aggressive.
Less aggressive.
We are not we are less worried for sure than someone who's having a higher grade of the Gleason score, which is between 3, 4, and 5. So if you go up to a Gleason score of 8, for example, it's more.
So lower the grade cancer doesn't need aggressive treatment, probably removal of the prostate?
We always try to be as least aggressive as possible.
Conservative, yes.
Exactly. Like we try to be conservative as much as we can.
Right. So you mentioned about active surveillance.
Yes.
Can you please explain that a little bit in detail?
So active surveillance, basically, when I have a patient that does not have an aggressive cancer, and I know that the patient is reliable, they will come back, we don't need to treat. We can wait. We keep following the patient. It doesn't mean that you just go away. We follow you. We repeat the PSA test. We repeat the rectal exam. And sometimes it would mean that you might need a repeat of the biopsy within 1.5 to 2 years to make sure we are not having an upgrading, or the cancer is not actually 6, it might be 7 or 8, and we're just missing it from the biopsy. So we sometimes have to repeat the biopsy with the active surveillance.
If some patient is not even eligible for surgery, say because of other health-related reason, can they enter into the surveillance program?
Well, it depends on their, yes, for sure. But at this point, we might have other options for them as well. So we might have the radiation or the hormonal therapy.
Yes. Now, about the treatment options available, you mentioned about the surgeries. So what are the different types of surgical options available?
So we have the removal of the surgery. We can do it open, or we can do it laparoscopically. If we have the robot, we don't have the robot in Thunder Bay. It's a very expensive machine. There is the robotic surgery that's to remove the prostate, and this is available in Toronto and Hamilton. This is another option. So these are surgical options for.
Maybe we'll take a short break and we'll continue with the treatment part in the next part. Please stay away for the last part. Thank you. Welcome back to the show, Talk with Your Doc. We are talking about prostate cancer awareness with Dr. Walid Shahrour. Dr. Shahrour, you're mentioning about surgical options, and you mentioned about robotic surgery, open pelvic surgery, and there is another scopic surgery. What do you call it as? Through the scope, laparoscopic surgery?
No, laparoscopic surgery is through the abdomen. We make small holes. The other, like endoscopic surgery, which is basically what we call the transurethral surgery, usually it is not made for prostate cancer. It's made for enlarged prostate.
Okay.
For some patients with prostate cancer, we can do that if they're obstructed and they need to be required to pee. At this point, we would do the transurethral or endoscopic surgery. But there are other options, there are, for example, other treatments like the.
What are the other than the surgical options? You mean to say medical treatment or hormonal treatment?
There is hormonal therapy, and usually we can combine the hormone. It's basically a castration, kind of chemical castration to the patient, and it can be combined with radiation, and it can actually help or boost the effect of the treatment.
So the reason being that the prostate cancer is dependent on the hormone supplement. Hence
it needs testosterone. Most of the time in the beginning, it needs testosterone to thrive. And we kind of block that, and we try to basically shut off the input from there.
Correct. Now, what sort of treatment and screening options and treatment plan you have here at the Thunder Bay Regional?
So since we started the diagnostic assessment program, we have been able to reduce the wait times, and now we have been doing a lot of talks. We have actually this year we hosted the second annual Men's Health Day. So we are very fortunate in Thunder Bay to have a very active prostate cancer patient group. They're, I think, one of the most active groups I've ever seen in the country. And we are hosting yearly a day where urologists are there. This year, for example, we had urologists, we had cardiologists, we had, I think, psychologists, we had internists coming in, talking to men. It's an open invitation for everybody.
People come and ask questions.
People come and they listen to talks, they ask questions, they come in, they have rectal exams if they want, they have their PSA done for free, and we are encouraging people to take care of their health. They know more, and if you know more, you would not miss out. So we're very fortunate. We have been doing this now for 2 years, and we have had so many sponsors trying to promote men's health and prostate cancer awareness. Now, in the regional, we have already started the MRI program for the prostate cancer detection. We have also, we're on our way, hopefully soon, to do the transperineal, which is basically one other option of doing the prostate cancer, the prostate biopsy. And it means it's less infection for the patients, and hopefully even better outcomes, I hope, in the future. So this is also one thing that we're hoping we're going to be getting, like we're already starting, but we're not there yet.
And you are raising the funds for that probably?
We're raising the funds for that. That's
So
like
anybody wants to help, they can contact Thunder Bay Regional?
They can always contact the foundation, and the urology group has, like, we have the accounts, and we're trying to collect money for that. But hopefully, and we have people like we're aware about this, and they're trying to help us, and hopefully this would be something that we can, next time we talk about what we're doing here at Thunder Bay for that.
For sure. Any latest advances like vaccine coming up? I heard about the prostate cancer.
So vaccine, like it's usually in later cases, in very advanced cases and it's very expensive. Basically, it's a customized.
It's in use now. People are using it.
Well,
or is experimental still?
There are experiments. There are things showing some evidence for it, but again, it's not widely used. It's not something that we are using in Canada. So I would not be able to say we have it.
Okay.
I don't know if in Toronto maybe they might have it on an experimental basis, but still, it is.
So what is this vaccine about?
So basically, we take part of your cancer, and we, as if we're making, like when we take the regular vaccine, and we take the bug, and we develop a vaccine or a strain of it. We are doing the same thing with the prostate cancer, but it's for each patient. We look at it, and we take it from the patient. We develop a vaccine against it, and
then inject it.
We inject it to the patient and give it back to the patient, and then the patient starts to build their immune response against the prostate cancer. It's a beautiful idea. There are some thoughts behind it that, you know what, prostate cancer is always mutating and changing its features. So how good is it? That's why it is still under the microscope.
There's no data available as such.
Not yet.
Not yet.
Not there yet. It's not part of the treatment stream.
Right. So only best strategy to prevent prostate cancer is healthy living and frequent screening, probably.
I would say for the screening part, we need to discuss it with the doctor, because you need to understand the benefits and the drawbacks of the screening. Because also, if you're over treating or over screening, or if you're not understanding the possible side effects from infections from the screening, for example, or if you get a biopsy, or from over treating the prostate cancer, that you might not even benefit from it. We always say if the patient has less than 10 years, for example, of life expectancy, no need for PSA screening. So I believe that screening is very important as a urologist, but I think it has to be tailored, and it has to be a discussion, and the patient needs to be aware.
Okay. And any statistics about the patient's survival after the treatment of prostate cancer? Like what is the percentage of 5-year survival?
I think 5-year survival is almost close to 100%.
100%.
I tell the patients, this is becoming a chronic disease.
Yes.
You have diabetes, similar to diabetes. You just have to accept that you might have prostate cancer, and you're going to live with it. And if you, even with a treatment or not, it will take a lot of time to.
It won't kill you all of a sudden.
It would not kill you all of a sudden. And even with the aggressive cancers, it's not a death sentence. We have a lot of treatment options available to help slow it down, make you have a normal life.
So if the cancer of the prostate had spread to, say, bone or other parts of the body, what sort of treatment options? They have a chemotherapy?
There is chemotherapy. We have the hormonal therapy that can actually shut off the testosterone in the body. We have radiation therapy that can actually go and hit the bones and the areas which are affected. So we have a lot of options.
And there is a radiation therapy for the prostate cancer itself, right?
Exactly. We have the radium, like we can actually like when it's in the bones, we can actually use a certain, not only the radiation therapy, we actually have a certain like drugs that can actually hit in the bones.
To target it.
Target the cancer in the bones.
So no need of giving radiation to whole body, just that particular part.
Oh, for sure. And in the regional here, we have like we have excellent radiation oncologists who can target the bones and the areas there, and we have even drugs that we can give the patients which can target the bones without the external radiation.
Yes. So prognosis is even better.
We have been having a lot of advances in prostate cancer, and there's always something new and trying to extend the life expectancy of the patient. And you look at like the 10-year survival is like 98% or like 97%.
So that's good news for all the patients then.
I think patients, you just need to be aware about it and take care of yourself.
Not to get panicked with the prostate cancer
No
diagnosis.
need to panic at all. Like I always tell the patient, I'm not worried. You should not be worried.
Thank you, Dr. Shahrour, for coming
Thank
to
you
the
so
show.
much.
Thank you, everyone, for being part of the show. Thank you so much.